Welcome to the Pegasus Learning Platform. Pegasus is your home for clinical simulation and learning resources. This presentation will cover burns and the rule of nines, understanding the pathophysiology of burns, percentage of body surface area affected, and the Parkland formula. This is a multi-use presentation appropriate for content overview and clinical competency. When we are caring for a burn victim, we must establish the percentage of body surface area burned. We're going to start with the arm. Remember the rule of nines? 9 is the rule, which means it's going to be 9, a multiple of 9, or half of 9, except for the groin, which is 1%. So if we can remember that our arm is 9, then we can figure the rest of this out. So for our patient's arm, this is going to be 9% for the arm and hand. So our patient's right arm and hand is 9%. The same for the left arm and hand, that's going to be 9%. Our leg is twice as big as our arm, which is going to be 18% for the right leg and 18% for the left leg. The total anterior torso is 18%, and that breaks down to the chest as 9% and the abdomen as 9%. The same for the total posterior torso at 18%, with the upper back at 9% and the lower back at 9%. The head and neck is 9%, and the groin is 1%. If you add those numbers up, you'll have 100% of the total body surface area. We're going to use the Parkland formula to determine the amount of IV fluid to administer in the first 24 hours from the time of injury. We need 3 variables. One is a constant variable at 4 milliliters. The other 2 are subject to change. Those are going to be the total body surface area burned and the patient's body weight in kilograms. Those will be unique to each patient. So we're going to multiply 4 milliliters by total body surface area burned and the body weight. And in the first 8 hours, we're going to give 1/2 of that. And in the next 16 hours, we're going to give the other half of that. Okay, it's practice time. Remember, when we are caring for a burn victim, we must establish the percentage of body surface area burned. For this patient, they've burned their whole right arm. That's 9%. They've burned their whole right leg. That's 18%. And they've burned their abdomen, which is 9%. Remember, the total anterior torso is 18% with the chest at 9 and the abdomen at 9, and they've just burned their abdomen, so that's 9%. We're going to add that up. 9 plus 18 plus 9 is going to give us 36%. So this patient has 36% of total body surface area burned. We're going to use this number to determine the amount of fluid to be administered in the first 24 hours from the time of injury. Now we're going to determine the amount of IV fluids needed for our patient. We have our 3 variables, our one constant, which is 4 milliliters. We need the total body surface area and the patient's weight in kilograms. This equals the amount of fluid needed in the first 24 hours from the time of injury. So we have our 4 milliliters times 36% of our patient's total body surface area was burned. And this patient weighed 90 kilograms. We multiply those together, and we got 12,960 milliliters. Half will be given in the first 8 hours. That's 6,480 milliliters. And the other half will be given in the next 16 hours. So we have 6,480 milliliters. We're going to practice again. We know this specific patient weighs 70 kilograms. Remember, we must calculate the percentage of total body surface area burned, and we use that number to determine IV administration. We also need the patient's weight in kilograms, which we have 70 kilograms. This patient burned their whole posterior torso at 18%. They burned the back of the right arm, so half of 9 is 4.5%. They burned the back of the right leg, that's 9%. Remember, the leg is 18%, so the back half would be half of that at 9%. And this patient burned their whole left arm at 9%. We add that up, 18 plus 9 plus 4.5 plus 9 gives us 40.5%, and that's the total body surface area burned for this particular patient. Now we need to calculate the IV fluids needed for this patient. We have our three variables: 4 milliliters, the total body surface area burned, times their weight in kilograms. That will equal the amount of fluid needed in the first 24 hours from the time of injury. So we have our 4 milliliters times the 40.5% of their total body surface area that was burned, times their weight in kilograms. That gives us 11,340 milliliters. We give half of that in the first 8 hours. So for the first 8 hours, we're going to give 5,670 milliliters, and in the next 16 hours, we're going to give the other half, 5,670 milliliters. We have some considerations for our burn victim. First, determining the total body surface area affected is essential. This helps us to identify the extent of the injury as well as calculate fluid needed in the first 24 hours from the time of injury. The location of the burn is an important consideration because it can affect patient needs. We must also determine classification based on extent and depth of the injury. The depth of the burn can help indicate time for healing and likelihood of scarring. We must also consider the burn depth. Superficial thickness. This affects the epidermis. There are no blisters. The skin blanches when pressed. Healing takes about 3 to 6 days, and there's no scarring. Superficial partial thickness. This affects the dermis. Blood supply to the area is reduced. Blisters and weeping surface are present. Healing takes about 10 to 21 days, and there's no scar, but maybe pigment changes. Deep partial thickness. This is deeper into the dermis. There are no blisters. It's red with white areas. Healing takes 3 to 6 weeks, and there's scarring, and they may need a graft. Full thickness. This is destruction of the epidermis and dermis. There's hard leather eschar, deep brown, black, maybe red and yellow areas. Healing can take weeks to months. It depends on the blood supply. There are scars. You need removal of the eschar, and you may see contractures. And then deep, full thickness. This extends beyond the skin to muscle, bone, and tendons. It's black with no sensation. The eschar is hard with no elasticity. Healing can take months, and grafts are required. Burn location is also a consideration. For the head, neck, and chest area, we need to consider respiratory system issues. For the face, eyes, and also respiratory system issues. For the hands, they may have problems with activities of daily living and also potential disability. Perineal genital area, this is often contaminated by feces and urine. We need to consider burn pathophysiology. We have increased permeability of capillaries which occurs. This causes plasma to leak from the vascular space into the surrounding tissue. When fluid is lost from the vascular space, organ perfusion is diminished. You may see reflexive tachycardia that occurs due to hypovolemia and decreased cardiac output. Blood flow to the GI system and renal system decreases. Fluid loss through the injured site increases insensible water loss. Blood pressure drops due to hypovolemia. There are some procedures for circumferential burns. These are burns that circle a limb. Escharotomy is one. It's an incision through the eschar to relieve circulatory compromise. It's generally not painful because the nerves are destroyed in that area. There's also a fasciotomy. This is an incision through the skin and fascia when escharotomy is unsuccessful. This is painful and it's done under general anesthesia. There are also different types of wound debridement to consider. One is surgical debridement. This is removal of tissue in the operating room. Another is mechanical debridement. It's the use of sponges or washcloths to debride eschar. Forceps and scissors can be used to remove and lift away tissue. There's also enzymatic debridement. Collagenase, which is an exogenous proteolytic enzyme, it breaks down and digests collagen. Necrotic tissue will then detach. And there's biological debridement, which is larval therapy. These release enzymes that dissolve necrotic tissue from the wound. There are different wound coverings to consider. One is an autograft. It's the patient's own skin from a healthy area transplanted to the area of injury. An allograft is human cadaver skin. There is a risk of transmission of infection. Xenograft is animal tissue. We need to, again, monitor for infection. There's also artificial skin. It's animal collagen and cartilage. It forms a structure for fibroblasts to adhere. This will then dissolve. Cultured skin, the use of patient's own cells to grow new skin in a laboratory setting. A few additional things to remember include Curling's ulcer. This is acute gastric erosions. It's caused by reduced plasma volume, which causes necrosis. This causes plasma to leak from the vascular space into the surrounding tissue. Your patient will probably need a urinary catheter for strict intake and output measurements. And IV fluid administration goals includes maintaining a urinary output of 30 to 50 milliliters per hour. When giving medications, we should avoid intramuscular and subcutaneous injections. Your patient may need protective isolations because they are at risk for infection. Their diet is also a consideration because victims with major burns may require more than 5,000 calories per day due to dramatically increased metabolism, and we need to keep the patient warm. This presentation is a brief overview only and is appropriate for review and continuing education. Please note that the care and treatment of burn injuries involves more than this presentation covers. Thank you for your attention to this presentation offered on the Pegasus Learning Platform.